All right. Good afternoon, everybody. Thank you for joining us today. My name is Andrew Doffney, and I'm the Instruction and Outreach Librarian at the New Jersey State Library. Our speaker today, Dr. Lesniak, is finishing up with a patient. He will be with us momentarily. So in the meantime, I just want to go over a few of the housekeeping items, and then hopefully Dr. Lesniak will be on very shortly. Today, Dr. Lesniak is going to be talking about a few of the conditions related to our eyes that result from as we age. So he's going to be talking about cataracts, glaucoma, and macular degeneration, talking about some of the symptoms and treatments available for them. But we will be taking your questions at the end of his presentation, but you can feel free to submit them at any time using the Q&A or the chat feature in the Zoom dashboard. There will be a survey available at the end of the webinar. So if you have time, we ask that you please complete the survey. We really appreciate any and all feedback that you can give us. And then if you're interested in more information about age-related eye conditions and care, or maybe where to go, the Cleveland Clinic has a fantastic site that's available on the screen there. So I encourage you all to look at that at your leisure, and I will be sending that out in the chat once we start. And then I just want to do a brief overview of the Zoom dashboard as well. This is what your dashboard should look like if you're using a PC or a Mac. If you're using a mobile device, the dashboard may look a little bit different, but all the features will still be there. In the bottom left-hand corner, you can check your audio settings. So if you're using an external listening device, like a headset or earbuds, you can check to make sure that's connected properly there. At any point during the presentation, if you do have any issues, there is a raise hand button here in the middle. You can click on that and that will alert me. I will send you a message in Zoom and hopefully be able to resolve any problems that you are having. And then, as I mentioned, if you do have any questions, there is the Q&A and the chat buttons here. You can use either of them to get in touch with us, and we'll be happy to, again, address your questions at the end of Dr. Lesniak's presentation. So we're going to give him a few more minutes. He did say that he had a tight schedule today, and that he would probably be on a little after 12. So if you don't mind waiting, we would really appreciate it. He is extremely busy, and we really appreciate him taking time out of his schedule to talk about this. So. And welcome, Dr. Lesniak.
Good afternoon, everyone.
All right, you can go ahead, and I just finished my intro, so you can go ahead and start the presentation.
Fantastic. Thank you, Andrew. Can everybody see the slides?
Not yet, you have to share them.
Oh, that's right.
All right, there you go.
So good afternoon, everyone. If anybody has any questions, we have an hour. If you want to stop me during the presentation, or we can
We'll wait till the end.
answer all the questions at the end. But I will be talking today about the aging eye. Again, my name is Sebastian Lesniak. I'm an ophthalmologist with Matossian Eye Associates. We have an office in Hopewell, New Jersey, Hamilton, New Jersey, and Doylestown, Pennsylvania. I specialize in general eye care, cataract surgery, and cornea. So any corneal issues, cataracts, or just general eye exams, I'm more than happy to see patients for those conditions. So let's talk about the aging eye. What happens as we age? And it's very common, very normal for vision changes, for vision to change and deteriorate with age. Many of these issues are treatable, so it's very important that they're diagnosed early and treated appropriately. And we'll go through the whole list of eye conditions, but I will tell you that the easiest, most common, and sort of obvious thing is updating your glasses. Sometimes patients have never worn glasses, their vision becomes blurry, and they're surprised to find out that all they really need is a pair of glasses, whether it's for reading or distance. And they're very surprised and they say, well, I never had glasses, never worn glasses. But sometimes that's what it takes. So it's not necessarily a disease or just if you're not wearing glasses, you're not taking full advantage of your vision. So common problems in adults which may change the way we see things. Now, these are sort of the top three things that we will see as ophthalmologists, outside of not having your glasses updated. Number one would be um, cataracts, and cataracts are just like gray hair. This is what I tell my patients. Everybody gets cataracts. They usually start at age 50. They slowly progress. Most of our patients will end up having cataract surgery sometime between age 70 to 75. Uh, it's a very wide uh, range. I've had patients as young as 47 and as old as 95. So every patient's different. Glaucoma is another common disease. Glaucoma causes loss of peripheral vision. You see in the lower right corner that there's a difference between the couple in the kayaks, and then someone with glaucoma would only have this keyhole vision where they only see the center. So that's what happens with glaucoma. Um, the person uh, planting the flowers, as you can see, she's kind of hazy. It's just not clear and kind of hazy. So that would be what you would see with cataracts. And I have some other examples what macular degeneration does and how it affects vision. But cataracts, glaucoma, and macular degeneration, I think, are the top three conditions that we diagnose in our patients. So let's briefly just discuss the anatomy of the eye. We'll uh, just kind of go over the common terms uh, that you might hear in the ophthalmologist's office. Andrew, can people see my pointer? So for example, when I circle the cornea, can people see that?
Yes.
Okay. So the cornea is the front clear part of the eye. I tell my patients that this is like the windshield of the eye. The light passes through the cornea, it gets focused through the cornea. Um, Now, the opening in the colored part of the eye, by the way, the colored part of the eye is called the iris. Some people have blue eyes, so blue iris. Some people have brown eyes. Some people have green eyes. But that colored part of the eye is called the iris. It is shown here as this sort of pinkish flap in cross section. The opening in the iris is called the pupil. The pupil appears to be black, but it really isn't black. It's just that's the keyhole into the eye, or opening through which the light passes into the eye. So we define the cornea, the iris, the pupil, or the opening in the eye, and then we reach the lens. The natural lens is something that we are all born with. When that becomes cloudy, we call that a cataract. So cataract is nothing more than a cloudy natural lens. And inside this posterior cavity um, is something called vitreous, not labeled, but that's the gelatinous substance that fills this cavity. The orange layer, or I sometimes explain to the patients that it's like a wallpaper that coats the inside of the eye, is called the retina. Now, the very center of the retina, the most important part of the retina, is called the macula. That's where macular degeneration occurs. And finally, we have the optic nerve. The optic nerve, you could explain it as quote unquote a cable that connects the eye to the brain. So all the visual signals that the eye collects get converted to a signal, and that gets passed to the brain through this nerve called the optic nerve. So macular degeneration would occur here in this region of the retina called the macula. Glaucoma is high eye pressure that actually causes disease of the optic nerve or deterioration of the optic nerve. And cataract means clouding of this structure called the lens. So let's discuss cataracts in a little bit more detail. Again, we talked about this lens becoming cloudy. You can see, these balloons on the left are nice and clear, and the colors are vibrant. This picture here, you see that they're not as sharp, not as clear. They're a little bit blurry, and all the colors are sort of, they look like an old movie. Everything's kind of brownish, not as vibrant. The blues are hardly blue at all. So this is actually a very good simulation of what someone's vision would look like when they start to develop cataracts. And when I talked about the cataracts being clouding of the natural lens, this is an example of a clear natural lens, which we are all born with. And up until age 50 or so, we all have this lens, nice and clear. After 50, this natural lens becomes cloudy. It starts off as this yellow greenish color, and then it turns into a brown sort of haze, and that is why we see everything as sort of like this yellowish brownish color, because the cataract affects our vision. Sometimes I tell my patients cataracts are similar to as if you were wearing dirty sunglasses and you had them on 24/7. And after cataract surgery, it will be like removing those dirty sunglasses. So cataracts are the primary cause of reversible vision loss in the United States. The key here is that it's reversible. Cataract surgery is really, it's almost a miracle to some patients, because they can have virtually no vision, no useful vision, and removal of the cataract restores their vision to what it was when they were, let's say, 40 or 50 years old. So it can be life-changing, and it's something that is a routine procedure. It takes on average 10 to 15 minutes. Patients do not go to sleep for this procedure. They the anesthesiologist stays in the room with the team, but the patient stays awake, doesn't have to be put to sleep under general anesthesia. So again, the nice thing about cataracts, or the one positive thing about cataracts, is that we can treat them, and the vision loss caused by cataracts is completely reversible, which is obviously an excellent. So most patients with cataracts have excellent prognosis. And again, we see a picture of a clear lens here on the left, and this is what the lens would look like with the cataract. So there are some common misconceptions regarding cataracts. Cataracts are not a film over the eye. As we said in the previous slides, cataracts are simply your natural lens, which used to be clear. That natural lens is now cloudy. And it's like looking through dirty sunglasses or shower curtain or frosted glass. Cataracts are not caused by straining the eye. So just because you're spending a lot of time on the computer, or you're spending a lot of time reading books or watching TV, that will not cause a cataract. I sometimes tell patients cataracts it's the most common cause of cataracts is age. Every patient over 50 will start to develop cataracts, and there's not much you can do about it. Just like you can't avoid getting gray hair. Everybody will eventually get gray hair. Um, Cataracts do not spread from one eye to the other. It's not an infectious or contagious process. And it says it is not irreversible. So basically what the last bullet says, it's something that we can fix, and often the prognosis is excellent. Causes of cataract, I sort of alluded to this in the previous slide, but age is the most common cause of cataracts. On average, at age 50, they start. Everybody will get a cataract if you live long enough. Diabetes can cause development of cataracts earlier in life. So, for example, younger patients, especially the ones with type 1 diabetes, can get cataracts in their 20s or 30s. But even type 2 diabetics might get their cataracts earlier than someone who does not have diabetes. Prior eye surgeries, for example, retinal surgeries, if someone has a retinal detachment and needs to have a retinal detachment repair surgery, that will often result in the cataract, which again, we can fix. Eye injuries, especially severe eye injuries, and prolonged steroid use. So both oral steroids like prednisone or topical eye drops such as steroid eye drops can accelerate cataract development. Symptoms of cataracts, so we briefly talked about this, but increased glare, especially at night. So when you're driving at night and when you're looking at that oncoming vehicle and the headlights are causing lots of glare, that's very commonly because of cataracts. Color vision, we saw in those previous pictures how the blues no longer look blue, they look brownish. Patients will often change their lifestyle. For example, patients will just avoid driving at night, and they may not know why all of a sudden they don't drive at night. They won't go out to get groceries after, let's say in the wintertime, it gets dark at 5 p.m. and they won't go out. They're afraid. They don't feel safe on the road. And oftentimes that's due to cataracts. We have a special test in our office called functional vision analyzer. And even if you can read the eye chart all the way down to the 20/20 line, that's reading black letters on the white background. The device called functional vision analyzer can assess whether cataracts are also causing decreased contrast sensitivity. So what this functional vision analyzer does is it tries to determine whether patients have trouble seeing shades of gray, because seeing black letters on the white background, such as a typical eye chart in the office, is much easier to read those letters as opposed to reading gray letters on the white background, or very subtle gray letters. And patients with cataracts will have a lot of trouble seeing shades of gray. So how do we treat cataracts? We first often will just prescribe glasses, and if glasses no longer help, then we recommend cataract surgery. And I always recommend cataract surgery to patients when their vision no longer meets their visual needs. So if the patient tells me that I can't drive at night, but I wish I could. If the patient tells me I can't read, I'm an avid reader, I can't read anymore, I can't read small print, or they can't watch TV, or they have trouble walking down the stairs, that's when cataract surgery is recommended. And there's this category of activities called ADLs, or activities of daily living. So just basic daily activities. If any of those are affected, if the patient has to change their lifestyle, then cataract surgery would be recommended. It's an outpatient surgery, meaning you don't have to be admitted to the hospital. You don't stay overnight. It's a procedure performed in an ambulatory surgery center, meaning you walk to the surgery center and you walk out. You don't stay overnight. And it's usually done with local or topical anesthetic, meaning you don't have to go to sleep for the surgery. Anesthesiologists will give you anesthesia through the vein to keep you calm and comfortable, but you do not have to be put under general anesthesia. So you breathe on your own, you hear everything, you stay awake, which is much safer for the patient. And finally, cataract surgery is very, very highly successful. Most patients do very well and are very happy with the outcome of the surgery. And there are many different types of intraocular lenses. So what I haven't mentioned, let me show you on the slide. When that natural lens comes out, um, it gets replaced. Because if you think about it, this natural lens has a function. Just like most bones in your body have a specific function. You can't just remove a bone and expect the patient to be able to walk. Or remove a bone from the arm or the wrist and expect the wrist to work properly. So if you remove the lens, you have to replace it with something. So we replace it with an artificial lens. Let's get back to the slide. So this is a great example. This natural cloudy lens gets removed and it gets replaced with an artificial lens implant. These artificial lenses are made of very specialized plastic called acrylic, and they're basically, I tell my patients, these lenses last for the rest of your life. They're the lenses that I use have been on the market since 2001. There's never really been any problems with them. So in most cases, they will essentially last for the entire lifespan of the patient. So this is a very, very successful surgery. And when I say last, it means that these lenses will remain clear. You do not develop a cataract again. Once you have an artificial lens in your eye, it stays clear. There are many different types of these intraocular lenses. The basic lens is called monofocal. It gives you distance only. There are some more advanced lenses, such as toric lenses, which also correct astigmatism. If you're not familiar with astigmatism, astigmatism means that the surface of the eye is not round, it's oval, like an American football or like an egg. If patients have astigmatism, astigmatism is corrected with eyeglasses, but if they want to get rid of glasses, then that astigmatism can be corrected with what's called a toric lens. There are lenses called extended depth of focus. That means that they give patients great vision for distance, but also at the intermediate range. So for example, dashboard, computer screen is still in focus along with objects that are far away. Because with the standard monofocal lens, you can only see well at distance. So anything at the intermediate range or up close will be blurry and you will need reading glasses. But with these more advanced lenses, we can also give patients freedom from glasses at the distance and intermediate range. Finally, multifocal lenses give you clear vision at distance, intermediate, and near without glasses. And we also offer a lens called light adjustable lens. That is a very, very advanced, newest lens in our arsenal. And the light adjustable lens can be adjusted in the office after surgery. So for example, if the patient desires a little bit more distance vision, we can make that adjustment in the office. If the patients actually want more intermediate or near vision, that can be adjusted in the office after surgery so that we can, again, get rid of glasses. So can cataracts grow back? The answer is no. However, there is a condition that often occurs after cataract surgery, and it's called posterior capsular opacification. So some patients refer to this as an after cataract or secondary cataract. So it's a little confusing, but the bottom line is cataracts do not grow back. The way I explain it to patients, and again, this is very common, that sometimes cloudiness can form behind the cataract implant. The implant itself is fine, but when this cloudy membrane forms on the back of the implant, to the patient, it will look like as if the cataracts came back. And it's such a common uh, occurrence that I would say about 30% of my patients at some point develop this cloudy membrane after cataract surgery. And we have a laser in our office called YAG laser that clears that cloudy membrane. And you can see that on the left-hand side, there's a cloudy membrane, and in the right-hand side, that membrane was cleared with laser light. The periphery, you can still see remnants of that membrane, but the periphery is not as important because what's important is the lens that's right behind the pupil. So the central lens is not nice and clear, and the patient enjoys clear vision after the laser treatment. So again, this is sometimes called after cataract, secondary cataract, officially posterior capsular opacification. And I tell patients is like it's a little touch up or cleanup that we perform in the office after cataract surgery. There are some advanced techniques that are utilized during cataract surgery. About 10 years ago, femtosecond laser was introduced and is available as a device that assists and in some cases replaces handheld cataract instruments. It makes some corneal incisions can be performed with the laser. The laser will also cut the cataract into smaller pieces, so it facilitates and makes the surgical process a little bit easier for the surgeon. So you may see this term femtosecond laser, which assists the surgeon during cataract surgery. There's a device called Aura, which remeasures the eye in the operating room and helps the surgeon select the most appropriate lens for the patient in the operating room. We also have this device available for patients who might need it. Oftentimes, LASIK patients who had LASIK in the past would benefit from this device. You might again see or hear about this machine that it is available to surgeons in the operating room during cataract surgery. But without getting into the details, Aura allows the surgeon to more precisely select the implant that the patient will get implanted in their eye. Dry eyes are very common, and or dry eye disease is very common, and we always pay very close attention to the cornea where we would diagnose dry eye. The reason being is if you don't diagnose and treat dry eye prior to cataract surgery, the patient's vision may not improve. Because often what happens is dry eye will get slightly worse right after surgery. So if the patient already has pre-existing dry eye, they will not be very happy after surgery. So our goal is to always diagnose and treat dry eye prior to cataract surgery to avoid any of these surprises afterwards. There are many ways to treat dry eye. The simplest, most common way is with eye drops. Most of us have heard of artificial tears. There are prescription eye drops, which are available as well. Examples include Restasis, Xiidra, Vivi. Some of you might have heard about these prescription medications. Punctal plugs are tiny little microscopic devices which get inserted into the bottom eyelid typically, and they allow more tears to remain on the ocular surface. Lid cleansers, omega-3 supplements, And we also offer treatments such as intense pulse light, IPL, or LipiFlow. These treatments restore oil production in the eyelids. So the eyelids have oil glands called meibomian glands, which produce oil. That oil is very important to uh, normal tear film, and this treatment called LipiFlow we would sometimes recommend prior to cataract surgery to make sure that the patient's dry eye is optimized, treated, and again that it doesn't get worse after cataract surgery. Now we're going to change gears a bit and we're going to talk a little bit about glaucoma. You might remember on the second slide I mentioned that there are the big three conditions that we often diagnose patients with when they come to see an ophthalmologist. Glaucoma being one of the three. We talked about cataracts already, and we'll talk about macular degeneration in a bit. But what is glaucoma? Glaucoma is a disease of the optic nerve. You will often hear about patients having high eye pressures, and that is a very common cause of glaucoma. It's not always that you have high pressures that lead to glaucoma. There are a small percentage of patients that actually have normal eye pressures and still develop glaucoma. But in vast majority of cases, if you have high eye pressure, you will develop glaucoma. And glaucoma causes damage to the optic nerve. Let me just go back a few slides to show you the optic nerve again. So this is the optic nerve. This is that quote unquote cable that connects the eye to the brain, and glaucoma will affect this region of the optic nerve and cause loss of peripheral vision, typically at first, and in end stages of the disease, it will cause complete blindness. So it's a very serious disease, but it often starts with elevated eye pressure. So as you can see, the eye is like you can think of it as a water balloon. It is filled with fluid, more liquid fluid called aqueous in the front, more gelatinous fluid called vitreous in the back. And the eye is under pressure. Normal eye pressure is between 10 and 21. And if your pressure is high for a long extended period of time, you will eventually develop glaucoma. So let's get back to our slide about glaucoma. So glaucoma, as we said, is a disease of the optic nerve, frequently associated with high eye pressures, and is the leading cause of blindness in the United States, especially among older adults. And unfortunately, glaucoma is not reversible. Once you lose vision from glaucoma, it is not something that can be restored or fixed or treated. We can only slow down the vision loss from glaucoma. We cannot reverse it or stop it. So it's very important to get diagnosed and treated early to avoid any permanent loss of vision. This is an example of how you would measure eye pressure in the office. Before this device gets very close to the eye is anesthetized. That's why you get those yellow drops put in the eye. You might be wondering, why am I getting numbing drops, yellow drops? But this is the gold standard. There are many different ways to measure the eye pressure, but this is called Goldmann tonometry. And this device gets very close to the ocular surface, and in combination with the yellow dye, it tells us what the pressure is. What are risk factors for glaucoma? Age is the most important risk factor. The older you are, the more likely you are to develop glaucoma. Patients with African ancestry are at higher risk. And also family history is extremely important. So for example, if your mother, your father, your first degree, second degree relatives have glaucoma, you're at a much higher risk of developing glaucoma yourself. So it's very important that you tell your eye doctor that you have a family history of glaucoma. So we talked about glaucoma causing damage to the optic nerve. That very tip of the optic nerve is called the optic disc. We can actually see this directly on exam. That's why doctors look inside your eye with those special lenses. And this optic nerve is a healthy optic nerve. The cupping inside the nerve is rather small, so this area that I'm outlining right now is called the cup, and it's quite small. I would say maybe about 20% of the total area of this optic disc. So this would be a healthy nerve. On the other hand, this is a very unhealthy optic nerve. This patient most likely has glaucoma. And we can see that the cupping, this is the outline of the cup or the indentation in the nerve. And there's even a notch here. So cupping represents loss of nerve tissue. So this means that all of this nerve tissue was lost from chronic damage, often from high pressures. And when you lose this tissue, you can never regain it. And this patient most likely has deficits in their peripheral vision. I'll show you some examples. So how do we diagnose glaucoma? Well, the most important thing is the eye pressure and eye exam, which we saw on the previous slides. But oftentimes patients will also get a visual field. Visual field is performed with this machine called the Humphrey visual field. Patients will be looking inside this sort of dome-like structure, and they will see flashes of light. And when you see a flash of light, there's a clicker here that the patient clicks. So when you see a flash of light, you click the button. And the whole purpose of this machine is to map out your peripheral vision and detect any deficits in your peripheral vision. As you may remember, glaucoma causes loss of peripheral vision, and end stages of glaucoma result in keyhole vision, which is very, very disabling to patients. So this is an example of a visual field. This is a normal visual field. There is a natural blind spot, which all patients have, but otherwise this would be considered normal. On the other hand, you can see that this visual field, all those dark areas is where the patient cannot see. So this is an example of a visual field of a patient with severe glaucoma. They basically have no vision in the upper quadrants of their visual field. As you can see, they only have some vision left in the lower quadrants. This person would have a lot of trouble reading. Driving would be very difficult for this patient. And unfortunately, as I stated before, this is irreversible. How do we treat glaucoma? The first most common way to treat glaucoma is with eye drops. Eye drops lower eye pressure. Remember, I said that glaucoma is often caused by elevated eye pressure. So how do you treat glaucoma? You lower the eye pressure. There are many different kinds of eye drops. We try to find the ones that work well for the patient, lower the eye pressure, and do not cause any irritation, burning, or allergies. So sometimes that can be challenging, but regular use of eye drops often lowers the eye pressure. And if it doesn't, we add another drop. If it still doesn't lower the pressure enough, we can add up to 4 or 5 eye drops. If that is no longer effective, there are laser treatments that can help control eye pressure. Those laser treatments are performed in the office typically, some in the operating room. And finally, there's major eye surgery that's specifically meant to be, specifically is performed to lower eye pressure. Oftentimes we try to lower the pressure with eye drops and lasers because glaucoma surgery is typically performed on patients with very advanced glaucoma who are not well, whose pressures are not well controlled with eye drops or laser. What are risk factors for glaucoma? Again, age. We briefly talked about this. Family history, African ancestry, not listed here, but that was in the previous slide. Use of steroids can elevate eye pressure. Narrow angles. Narrow angles is something that your doctor would diagnose in the office, but that can contribute to high eye pressures and glaucoma. Prior eye trauma, or uveitis. Uveitis is a medical term for inflammation in the eye. So if someone has chronic inflammation, history of eye trauma, they're at risk for glaucoma, along with all these other risks that we discussed. Glaucoma treatment, surgical glaucoma treatment can often be combined with cataract surgery. So for example, if a patient has cataracts and glaucoma, they can have the cataract removed, and at the end of cataract surgery, a surgeon can insert a stent. So you can see this stent enlarged on the left-hand side here. It is very tiny. This is just to show you how tiny it is. This is a penny. So tiny little device. And then this is on just a size comparison on the finger. So it's extremely small. This stent redirects the fluid in the eye and lowers eye pressure. So it is like a little tiny little pipe, and redirects that fluid from the eye into a drainage channel, so the fluid can drain properly from the eye so the pressure doesn't build up. So it's implemented during cataract surgery. So for the patient, it's just one trip to the operating room and they get both the cataract removed and they get the stent inserted. And it's a permanent opening or drainage channel inside the eye. And this is our third big topic that we're going to discuss today. This is, we'll talk about the macula. Macula, as you might remember, is the very center of the fovea. I'm sorry, the very center of the retina. So retina is all of this orange wallpaper, quote unquote, that coats the inside of the eye. So that's the retina. But the very center, most important part of the retina is called the macula. And macula is what allows you to see fine details, what allows you to see colors, and it gives you central vision. The retina outside of the macula gives you peripheral vision. So reading, watching TV, looking at fine details, colors, the macula is responsible for all that. But your peripheral vision comes from the peripheral retina. So what are the risk factors for macular degeneration? You'll see age listed as the #1 risk for cataract, glaucoma, and macular degeneration. So that's the most important risk factor. Racial background, in contrast to glaucoma, patients of Northern European descent are at higher risk for macular degeneration. Family history is also very important. So for example, if you have close relatives with macular degeneration, please make sure you tell your ophthalmologist about it, because we will be specifically looking for any early signs of macular degeneration. Smoking can increase your risk, obesity, poor diet. And when I say poor diet, you want to avoid unhealthy foods. You want to increase your intake of omega-3 rich foods such as olive oils, green leafy vegetables are what gets recommended, as opposed to unhealthy junk foods that we all know what those things are. Hypertension and heart disease can also be contributing factors to macular degeneration. So what happens? The macular tissue essentially deteriorates, and it results in loss of central vision. So as opposed to glaucoma, which causes loss of peripheral vision, macular degeneration causes loss of central vision. So you will be able to see the periphery, but you won't be able to recognize a person's face. You won't be able to read. And it usually doesn't cause total blindness. Again, you will retain some peripheral vision, but central vision, you will essentially see a black spot in the center of your vision. And this is the most common cause of visual loss over the age of 60. And there are two types. Some of you might have heard about the wet and dry type of macular degeneration. And this is an example of what happens. If you look at this newspaper, um, right in the center, you cannot see what the numbers or the names of I guess these are stock prices. It's blurry. Sometimes it's completely black right in the center. In earlier stages, you can see distortion. You see how this building is all of a sudden wavy. Well, the building's not wavy. There's a problem with the patient's vision, and they don't see straight lines anymore. The lines are wavy. When the ophthalmologist is looking inside the patient's eye, we see these yellow deposits called drusen. Drusen are cellular waste products, and they are visible on exam. We take photos to document the presence of these drusen. Patients will often have a few drusen in their eye, but having just one or two drusen is not macular degeneration. Oftentimes, you have to have a lot of them, and again, it's important to get your eyes examined at least once a year to make sure you're not developing macular degeneration. But again, drusen are these yellow deposits that we see in the photo. See, this person has probably close to 100 of these, and this person has macular degeneration, unfortunately. Another way to test yourself at home, it's a very simple test. You are looking at this grid. You want to look at the central dot, and you want to look at it one eye at a time, sort of like how I'm simulating, or you can just go like that. You're looking at the central dot, and you want to make sure all the lines are straight. This is you can download it from the internet. You can get a copy of this Emsler grid from your eye doctor, but if you notice waviness in these lines, it could be the earliest sign that you're developing macular degeneration or that your macular degeneration is progressing. This is an example of what someone would see with macular degeneration. The grid would be distorted and the lines are no longer straight. The dry kind, we said that there are two types. The dry kind is the most common. It's caused by aging, thinning of the macula, those deposits called drusen. How is it treated? First and foremost, with vitamin supplements. Some of you might have heard of AREDS 2 vitamins, that's the recommendation of the Eye Institute that performed the study. And recently, injections became available for dry macular degeneration as well. Not all patients qualify for these injections. Injections were in the past only offered to patients with wet macular degeneration. They were only approved for wet macular degeneration, but now we have injections for dry macular degeneration as well. Wet macular degeneration is a lower percentage, but much more severe. This is when patients develop leaky blood vessels. The disease is quite severe. It causes loss of central vision. And these days, it is most commonly treated with injection. So you may have heard of these. You may have had these yourself. You may know a neighbor or family member who gets eye injections for macular degeneration. And those are performed by retina specialists. You come to the office, and the retina specialist will inject medication directly inside the eye to treat macular degeneration. This is what happens. This is a picture of the macula, or the center of the retina. On the left-hand side, we see a normal macula. On the right-hand side, we see macula with swelling or edema. And these injections, you might have heard these names: Eylea, Avastin, Lucentis. These medications are commonly used as injections to treat swelling and fluid in the retina. This is abnormal here on the left, and this is what it should look like. I'm sorry, abnormal on the right, and this is what it should look like on the left when we take these photos. So, in summary, most people, as you age, most people will have good vision. However, you have to diagnose and treat problems early, because oftentimes, especially with glaucoma, whatever vision you lose, you can never recover. It's usually permanent with glaucoma. Macular degeneration is something that you can treat and you can improve vision. With glaucoma, you can only slow it down. And cataracts have the best prognosis because in the vast majority of patients, we can restore their vision. So I want to thank you all for attending this lecture, and we have about 10 minutes for questions. Does anybody have any questions for me?
All right. Thank you so much, Dr. Lesniak. If you do have questions, feel free to use the Q&A or the chat to get in touch with us. I will try to get through these as quickly. Um, can LASIK or PRK surgeries cause cataracts?
No. LASIK is a treatment performed usually in patients between ages 20 and maybe up to age 60, but it's meant to get rid of glasses. It does not get rid of reading glasses, but it typically does not cause cataracts because LASIK is performed um, on the cornea and cataracts develop inside the eye. So the answer is no.
Can you repeat the kind of vitamins that are recommended to treat macular degeneration?
So there are many brands, but the formulation is called AREDS-2, and it's spelled AREDS, AREDS, -2. That's the formula that was recommended by the Eye Institute after they performed a large study and determined that vitamins slow down the progression. The vitamins do not cure or reverse macular degeneration, but they can slow the progression of dry macular degeneration. So again, that they're called AREDS-2. There's many different brands that offer that vitamin formula.
Does the use of steroidal asthma medications cause or accelerate the development of cataracts?
The answer is yes. Unfortunately, the answer is yes. However, what you have to keep in mind that, asthma, if you ever had a experience with a relative or, we doctors have seen patients end up in the emergency room and they can't breathe. If you can't breathe, you can't live. So sometimes these medications are the lesser evil. But unfortunately, patients who use steroids chronically can develop cataracts. The positive or the good news here is that unlike glaucoma and macular degeneration, cataracts are treatable. And what I tell patients sometimes is if you develop cataract, we can treat it, we can fix it. But if you can't breathe, you can't live. So I would work very closely with your asthma specialist to try to minimize the steroid use. But if you have to use steroids, you have to breathe to live. And it's the lesser evil.
How successful are glaucoma surgeries?
Well, it depends on the patient. It depends if it's their first surgery, their second surgery, their third surgery. It depends on the stage of glaucoma. Um, Glaucoma is a very tough disease. It cannot be cured. It cannot be fixed. It cannot even be stopped. It can only be slowed down. So the goal is to lower the pressure and slow down glaucoma as much as possible. Some patients respond very well to glaucoma surgery. Some patients need multiple glaucoma surgeries because their first glaucoma surgery fails, the second one fails. It also depends on the type of glaucoma. There are certain types of glaucoma, such as neovascular glaucoma or uveitic glaucoma. Those types of glaucomas are often most difficult to treat. And the answer is that surgeries can be successful, but glaucoma, especially advanced and severe glaucoma, is a tough disease to treat. But it is treatable.
My mother had a cataract surgery and started seeing double vision afterwards. Why might this be, and is it common? Is there a way to fix that?
It depends what is causing the double vision. It depends if the double vision occurs with one eye open. If it persists with one eye open, then it's usually perhaps caused by the scar tissue that formed on the back surface of the lens. But if the double vision occurs with both eyes open, and if one eye is covered, the double vision goes away, that has to do with ocular alignment. So if your eyes aren't straight, you will develop double vision. It would be impossible for me to speculate on, about the exact cause. I would recommend seeing an ophthalmologist who can figure out what's causing the double vision. And if the double vision isn't severe, oftentimes it can be corrected with what's called prism glasses. If it's caused by the scar tissue behind the implant, then that scar tissue can be removed with laser. But again, it's very difficult for me to speculate about the exact cause.
Um, what is a macular hole?
Macular hole is a a an abnormality in the contour of the macula. Patients can have partial thickness or lamellar holes or full thickness holes, but as the name implies, it's essentially a hole in the retina. It's not the same kind of a retinal hole that some patients develop and need emergency laser treatment to seal the hole. This hole often, the macular holes typically develop because of traction forces on the macula from scar tissues, usually called macular pucker or epiretinal membrane. Uh, Macular holes can also occur as a result of trauma, and they're if you know someone who has a macular hole, you have to see a retina specialist, and they can give you more information about whether it's treatable or if it should be left alone. But it is essentially a hole in the macula, and you can see it on the photos that are taken in our offices when we examine our patients.
Of the different drugs for wet macular degeneration, what is the preferred medication given current research? And then also related to this, if you're diagnosed with wet macular degeneration in one eye, does taking the AREDS make a difference at this point? Injections were not discussed.
So I am not the best person to answer that question in terms of which one is the best, because these things change almost sometimes monthly. There's a new article that comes out. I gave you some examples of the most commonly used ones. Oftentimes patients get either Eylea or the generic one is still used called Avastin. But there are so many of these medications, and it seems to me, and I'm not a retina specialist, so I don't give these injections to my patients. So the best source of information would be a retina specialist. But it seems to me like every month there's a new one that comes out, and there's a new research that comes out and says that this new one is better than all the previous ones, and then the next month is another one. Um, the bottom line, again, your retina specialist is your best resource about which one is most appropriate to you. Now, to answer the second part of the question about AREDS vitamins, so AREDS vitamins are recommended for to slow down the progression of dry macular degeneration, but oftentimes patients will have dry macular degeneration in one eye and wet macular degeneration in the fellow eye. So I think that there's still benefit, they still benefit from taking the AREDS vitamins to protect the eye with the dry macular degeneration.
Can a vitreous detachment affect these other conditions?
Great question. So vitreous detachment is um, in the back of the eye. That posterior cavity called the vitreous cavity is filled with this gel-like substance called vitreous. And when we're born, it's more solid like jello. And sometime around age 60 or 70, it liquefies and separates from the retina. So vitreous detachment typically will not cause a cataract. It will typically not cause glaucoma. Um, it will not cause macular degeneration either, but it can result in a retinal tear and even a retinal detachment. It can sometimes result in bleeding in the back cavity of the eye called the posterior or vitreous cavity. We didn't talk about those conditions in this lecture, but to give you a simple answer, no, vitreous detachment does not cause glaucoma, cataracts, or macular degeneration, but it can result in retinal hole, retinal tear, or even a retinal detachment. And retinal detachment can cause loss of vision, so it's a serious condition.
There are still a few more questions, but I want to respect your time, Dr. Lesniak. Do you have
I
time to
still have
answer
a few
more?
minutes. No, we can
Okay.
we can go through them.
Okay. Um, what could be the cause of bright zigzag lines in the eyes?
So that can be caused by several things. If these zigzag lines occur in both eyes at the same time, and it's often difficult uh, to note to figure out, is it only happening in one eye or both? But what I tell my patients, if you cover one eye and then cover the other eye, and if you convince yourself that it's happening in both eyes at the same time, then it's possible that that's something called ocular migraine. However, if you're seeing zigzag lines in only one eye, and if they look like flashing lights or sparks or fireworks, that could be a retinal tear or detachment. And oftentimes, when that happens, you should see an eye doctor immediately. I would even seek, advice from an eye care professional the same day if you all of a sudden develop these sort of zigzag lines or flashes in one eye only. But oftentimes, if it's happening in both eyes, it will be caused by by ocular migraine. Patients usually do not develop ocular migraines later in life. Typically, it's something that they've experienced since they were 20 years old. It's more common, um, to develop it early in life, and then they come in. The symptoms appear sporadically, maybe a handful of times a year. If someone has ocular migraines and if they migraines all of a sudden occur weekly, then I recommend seeing a neurologist, just to make sure there's nothing else going on.
Related to that, we had a question, what can be done for ocular migraines?
There are medications that are typically prescribed by neurologists, and just like the the more common migraines that cause headaches, the goal of these medications is to prevent the migraine. Sometimes patients have known triggers for migraines, and they can have the same triggers for ocular migraines, so avoidance of those triggers. It's hard to tell sometimes what your trigger is, but neurologists can prescribe medications that lower or prevent lower the frequency or prevent ocular migraines.
Can you briefly address the difference between central serous retinopathy and macular degeneration?
Great question. Central serous retinopathy is often um, seen in patients who are type A personality, very stressed. So typical and typically seen in men, middle-aged men. It can also occur after a steroid injection. For example, someone can get a steroid injection in their knee. And what all these examples have in common is there's elevated levels of steroids. So when you're stressed, there's a natural steroid called cortisol that your body releases. When you get a knee steroid injected in your knee, then that steroid will spread throughout your body. But basically, it causes abnormal collection of fluid in the macula, and it causes distorted and blurred vision. Um, that is often something that will eventually heal itself. It can be treated with laser, but oftentimes we just watch it and eventually it heals itself. Whereas macular degeneration, very different cause, very different mechanism. Often it's not just fluid, but blood that starts to develop in the retina and starts to cause the retina to become thick. Um, and the treatment's very different. Again, the cause is very different. Macular degeneration is seen equally, I think, in men and women, and typically, as the age implies, it's age-related macular degeneration. Um, so different patient, different age, different circumstances, different mechanism, but similarly results in blurred central vision.
Is the visual test only for glaucoma? The visual field test, I guess, or is visual field only test for
No,
glaucoma?
that's a
Sorry.
great question. We use visual field testing for all sorts of different eye conditions. Just to give you the most common ones, most common one is for glaucoma to map out the peripheral vision, see if there are any deficits in peripheral vision. The second most common that my patients will get is when they take a medication called hydroxychloroquine or Plaquenil. We want to make sure that it's not causing toxicity. So Plaquenil is used to treat rheumatoid arthritis or other inflammatory conditions. Um, and then the third most common reason why you would get a visual field test is if a patient had a stroke that affected their vision, we would um, perform the visual field test, and we would see if there are any deficits in their vision. And then periodically we would repeat that test to see if it's getting any worse, if it's not changing. And then finally, I guess the fourth most common one is when patients have brain masses, brain tumors, or brain lesions. A common one is actually swelling or adenoma in the pituitary. Pituitary is a gland inside your head, basically hangs off the brain, and it can press on the optic nerves. And if it presses on because it becomes swollen and it presses on the optic nerves. If it presses on the optic nerves, it will cause loss of vision. So that's how we would determine that, by performing that visual field.
Are there supplements other than the AREDS2s that help promote and maintain eye health?
There are many different kinds of supplements. The one that was studied and is officially recommended is AREDS2, but omega-3s or fish oil are also often recommended, even for dry eye. Surprisingly, taking oral omega-3s can help with dry eye. There have been some studies that sort of contradict the effectiveness of oral omega-3s, but basically, AREDS2 is the one that's officially recommended, um, along with a healthy diet, um, green leafy vegetables, foods that are anti-inflammatory, so foods rich in omega-3s.
What is age-related macular scar tissue?
So it's part of macular degeneration. Patients can develop scarring in the macula that unfortunately is not treatable. Oftentimes, patients can, in end stages of macular degeneration, there will be large macular scar where they might have had bleeding in that spot previously. And unfortunately, it's not something that can be treated or fixed, but it's part of usually seen in advanced or severe stages of macular degeneration.
How common is it for patients to get lenses other than monofocus for cataracts?
So it all depends if they need anything more advanced. So for example, the astigmatism correcting lenses, I would only offer to patients that actually need to have their astigmatism corrected. But it's often comes down to cost. Multifocal lenses have an out-of-pocket cost. Monofocal lenses are almost always fully covered by insurance. So it just depends if the patients are willing to spend money out of pocket for more up advanced lens type. But they are very common actually. They're um, it depends on the geographic region, depends on the patient population, but I would say anywhere from 20 to maybe 50% of patients end up getting more advanced lenses. Again, depending on where you are in the country, what city you're doing surgery in, et cetera, et cetera.
Can wearing glasses help prevent any of these conditions?
No, wearing glasses will not prevent glaucoma, macular degeneration, nor cataracts. Although some some do say to wear sunglasses, uh, which can slightly reduce the risk of cataracts and macular degeneration. But but glasses, just prescription glasses, will not prevent any of these conditions.
Um, Can you have scar tissue that developed from macular hole surgery healing that cannot be seen by the doctor but presents as a smudge when looking through that one eye?
Oftentimes, scar tissue will be visible on the so the doctors may not be able to see the scar tissue directly, but a photo called OCT can often detect that scar tissue. That photo is very detailed, and if it's not seen on the OCT, it's most likely not there. But the defect in vision, we talked about visual fields previously, uh, can sometimes be diagnosed with a visual field dedicated to the macula.
Um, I have Sjogren's syndrome and have very dry eyes. I already have punctal plugs. Do you recommend a drop for resolving the dry eye irritation? I'm allergic to Pantanol and cannot use Restane types due to migraines.
So Sjogren's is a common cause of severe dry eye. Um, the patient seems already has punctal plugs, but I recommend on top of punctal plugs, I recommend artificial tears, and there's many different brands that you can experiment with and find one that doesn't cause any irritation. There are some additional treatments that we can perform in the office. Patients can even have special contact lenses called scleral lenses, or can have amniotic membranes placed on their eye to to help their surface heal.
Um, Again, so many OTC options for dry eye treatment. Do you recommend any brands or formulas?
That's a that's a great question. What I tend to do is I tend to give patients samples of many different kinds of drops, and I ask them to experiment and find ones that work well for them. I tend to recommend, large national brands. There were problems with over-the-counter eye drops a year or two ago. They were contaminated with bacteria and fungi to the point that patients were getting severe infection and even dying. Those drops were typically generic brands sold on Amazon or sold in CVS as the store brands. There's been very few recalls of the large national brands that are made here in the United States, so I tend to recommend those. So the big national brands would be Refresh, Sustain, although Sustain, there was one recall of a Sustain drop, but only one particular lot number and one particular type. But the big ones that everybody has heard about is like I said, the Refresh, Sustain, TheraTears, Soothe. So those are the ones that we would typically recommend. And they're typically made in the United States. So that's also important because a lot of the ones that were problematic were made abroad.
Is there still a recall in some of those brands?
So I am the most recent one that I was aware of was the Sustain Ultra. That recall was in December of last year. I haven't heard about any newer recalls, but that doesn't mean that these recalls haven't been recently issued. Um, but as soon as we hear about it, we alert our patients.
Sometimes my vision in my right eye gets blurry, like it's dirty. Moving the eye a bit can make it better, and sometimes washing it can also improve, but sometimes it doesn't wash away. Is this caused by cataracts or some other condition?
So, and I'm sorry, but I'm gonna have to get back to my patients.
Yeah.
Um, if the vision persists all the time, no matter what time of the day, no matter, whether the eye feels dry or not, it's not going to be typically dry eye. It might be cataract. But if the vision improves with eye drops or it improves at certain times of the day, then that's mostly probably from dry eye because cataracts don't change from hour to hour or day to day, but dry eye will fluctuate. So that's the easy way to tell.
All right. Thank you so much, Dr. Lesniak. We really appreciate it for all the information, and thank you everybody for attending. Everybody be safe, be well, and hopefully we'll see you soon.
Thank you so much. These were fantastic questions. I really enjoyed answering them, and I hope you guys enjoyed my presentation. Thank you again.